of pain and management of pain with opioids and with the WHO ladder. So we know that in certain situation, it will be very difficult for us to control pain, and I'm sure you might also have faced such situation. We don't know in such situation what to do, whom to call, etc., and we are helpless. So let's see what we can do in such situation. So Rajagopal sir will be covering those aspects in this session of difficult pain. So I'm not introducing sir because he has already taken two session for you. So it's over to you, sir.
Hello, everybody. Can you hear me okay?
Yes, sir.
Uh, I can't see everybody. Raju, is everybody giving us a smile?
Most of them, the videos are off, sir. I request all participants to on their video.
Yeah. Even if the video is off, please give me a smile. Thank you. Thank you, Geeta. I can see your smile, Sister Abeni. Very good. Uh, listen, we are going to talk about difficult issues. This is something that you are going to face. Raju offers you a course. You do it, hoping to treat pain. And unfortunately, next month, Ranjit Kumar is going to find that about one-fourth of the patients does not respond to everything that he is trying to do. And this session is intended at helping Ranjit and everybody else in this group to cope with that situation. I'm going to share my screen and show you a presentation. Intractable pain is a term that we commonly use. What it refers is a group of patients who do not respond to pain management in the conventional ways of pain management that you have learned already. The ladder that you have seen, including oral morphine, will take care of about 3/4 of all patients. That's all. Sorry, I wish I had better news to give you. But in about one-fourth of the patients, whatever you do with the ladder may not achieve satisfactory pain control. You may achieve some degree of pain, but the patient will still be miserable. So we are going to talk about what to do. We are going to talk about 3 steps. What we do to prepare ourselves, then reviewing the patient situation and our medications, and thirdly, about 3 different ways of handling it. This is what we are going to talk about. How do we prepare ourselves? Hey, when generally, I think maybe we all would do well to examine our own uh, conscience and see if this happens to you. When your treatment fails, examine your subconscious mind. When the patient comes again, do you say, oh my God, there he comes again? Do you then find fault with the patient? Doctor, the patient, as if blaming you, says, Doctor, nothing is helping. I have done everything that you asked me to. I am still in pain. We are irritated now. Irritated with ourselves, irritated with medical science, irritated with him. Let me see. How many times have you taken this medicine? 3 times. I told you to take it 4 times a day. You don't follow my instructions. If you don't follow my instructions, I don't want to treat you. In our subconscious mind, we will start rejecting him and in the process, start getting angry with him. These are things that we need to contemplate. Make sure that we don't fall into those traps. We need to learn to identify our emotions to ourselves. I am feeling helpless. I am feeling helpless, therefore I may become irritable. I have to be conscious of this. So, this is part of the preparation, and from there, we are going on to the first step in preparing. That is, we start by believing the patient. Sometimes, if whatever you do doesn't relieve the pain, you may be tempted. Hey, is this a supracortical lesion? Is it all in his mind? Maybe the pain is not real. Maybe he is malingering so that he can get more leave from work. Let us start by believing the patient. Every time, let us start by believing the patient. If he says he doesn't have pain relief, he doesn't have pain relief. Secondly, see, okay, is there any correctable factor? You and I'm not an oncologist. I'm not a neurologist. As a palliative care doctor, as an anesthetist, I may immediately think about nerve blocks. Are we missing any correctable factor? Very often, oncologists have a complaint against palliative care. Sometimes it is justified that we miss correctable factors, we miss treatment that should have been done. If your patient continues to complain of severe back pain, you need to see, is there a metastatic lesion in the back? In which case, radiation is the immediate thing to do. Refer the patient to the radiation oncologist. By giving radiation, may treat the pain, you will prevent a future paraplegia. Remember that. In a spinal metastatic lesion, radiation will strengthen the bone and prevent a paraplegia in future, and also treat the pain. Similarly, a bad chest pain, advanced lung cancer, maybe a single fraction radiation may ease the pain. So there are situations like that. And if there is a patient keeps complaining of chest pain, you examined the patient last month. You think you know the patient, but the patient has changed. Now he may have a pleural effusion. That may be the cause for the pain, not the lesion here. So always, you have treated the patient, you have given the ladder, he is not being helped. Look for correctable factors. And thirdly, check the adherence to treatment. We always give 3 or 4 medicines or sometimes more. It's difficult even when we are in full possession of your faculties. When you are confused with disease, sleepless, worried, you make mistakes. It is a minority of patients who will take your prescriptions to heart and you take everything religiously. If I ask everybody here, how many times have you yourself completed a course of antibiotics religiously? Every dose? A certain proportion of you would have done that. The majority of you, I fear, would be like me, forgetting after the third day when the cough has gone down. Remember, patients may make mistakes. Okay, and never be challenging. Have you taken all the medicines on time? If you have that threatening tone, they will say, yes, sir, or yes, madam. Instead, sit down with him. I'm sorry to see that whatever I have done has not relieved your pain yet. Come, let us see. Let us see how you are taking the medicine. Just in case there is an error, I can correct it. Tell me, how many times are you taking this? Okay, and this one, and this one. Check each medicine. If you do not get annoyed with them, You appear to be a friend, they will tell you the truth. If you are challenging in tone, how many times have you taken it? They will say, I've taken it just as you told me 3 times a day. When he knows very well that he did not. The medicine gave him a gastritis, so he stopped after 1 dose. He is afraid to tell you. Very common, very, very, very common. Patients are afraid of doctors. Unless you have that tone in your voice, they will not tell you the truth. So these are the 3 steps in preparation. Believing the patient about the pain, correcting the correctable, and checking adherence to treatments. Okay. Once we have done that preparation, we'll go to reviewing the status. What is the nature of pain? We talked about this when we discussed assessment. Nociceptive pain and neuropathic pain. Neuropathic pains are more difficult to treat. What exactly is the nature of the pain? The patient keeps complaining of pain. You ask a closer question. Then you find that though originally the pain was only here, now it has spread all over the upper lip. He is developing a neuropathic pain. And neuropathic pains, as I said, are harder to treat. We may spend a minute or two on that specifically, remembering that many pains can be a combination of neuropathic and nociceptive. I am spending more time on this specifically because neuropathic pains are one of the commonest reasons for failure of the ladder. There are other things. You may keep on giving analysis, your regime for the pancreatic cancer. A new partial obstruction may have developed. A new colic may have developed. At every visit, review the nature of the pain. And also, we will have to see is a psycho-social issue worsening the pain experience. On your first day of this course, I think I showed you a video of my colleague Smriti Rana, a clipping from a TEDx talk. Did I? A clipping on total pain.
Yes, sir, we have shown them.
That is a typical example. You remember a fisherman saying, the only thing I wanted was that my children should have an education. And once an assurance was given that their education will be supported, even if he is gone, his pain dropped from 5 to 1. Morphine had reduced the pain from 9 to 5, but to bring it down from 5 to 1, we needed this. This is not malingering, this is not psychiatric illness. Pain, by definition, is a physical and emotional experience. We know that. And we have to review the situation. Any number of examples I could have given, but then if I take too long, Raju will be very annoyed with me. And maybe we will have to think of interventions. How many anesthetists are in this group? I don't know. Like me, we can poke needles. A difficult pancreatic pain could well be treated by a celiac plexus block. A sympathetic induced pain is best treated by a sympathetic blockade. So nerve blocks, but also very simple things. Raju,
Yes, sir.
have you got the TENS machine with you?
Yes, sir.
If I stop share, will you show it to everybody?
Yes, I can show it.
Just hold it up closer to the camera, Raju.
So can you see it clearly?
So what it does is it has 2 electrodes. That machine is a simple thing like your electric torch. It gives out electrical currents at small intensity. I'm not showing it to teach the machine to you. That cannot be done unless I have spent one session on it. What I am trying to do is to show you there are things like this. This is called transcutaneous electrical nerve stimulation, TENS. Some kind of pains are easily relieved. Honestly, I myself, when I developed a musculofacial pain in my foot, I applied this for a week. It will not treat a severe cancer pain completely, but along with other things, especially in some neuropathic and myofascial pains, it can be a good additive. Thank you, Vishnu. What I am trying to do here is not to impress you with too many machines, but to tell you that at the conclusion of your course, you have learned some basics. You can learn the majority, treat the majority of patients. But that 1/4 of patients, call us. Contact me, contact Sunil, contact Arjun, contact one of us. We are here to help. Difficult pains by consultations, we can do. We can help. We will work together. This is only a basic course. It's a foundation course, remember. It is not building on the whole edifice. It's building only a foundation. Non-pharmacological measures will also include massage. Sometimes when your grandmother doesn't sleep for the whole night complaining of cramps, just try 15 minutes massage to her legs at night before she goes to bed. Maybe she'll sleep very well, and maybe your relationship will improve. Maybe the affection that you have between you will significantly improve. Let us not underestimate these things. So remember, in our first step, we had mentioned reviewing the nature of the nature of pain, and now we are reviewing the role for interventions and non-pharmacological measures. And in step 3, we are reviewing sorry, not only
Are you muted? So you're muted from your end.
how about now?
Yes, sir, we can hear you.
Oh, my cough was so powerful as to destroy the whole computer. So I was saying that we will review the nature of the pain, review the analgesic regime, and review the adjuvants. Please take a look at the prescription. Now, who do I see in front of us? Oh, because of sharing the screen, I cannot identify names. Somebody who wants to comment? Any problem with that prescription? Paracetamol 500 milligram TID.
It should be at least 6 hourly, 4 times a day.
Never ever prescribe paracetamol TID. There is a case for giving it SOS as required in some cases, but not for TID. It has to be given 6 hourly. Thank you very much. Sorry, you are the uniformed officer who answered. What's your name?
Abir, sir.
Abir, where do you work? Name the name.
I work in a cruise ship right now.
Okay.
In the US.
You are somewhere in the open seas at the moment.
Yeah, so right now I'm near to Singapore.
But
in the sea.
surprising that you have good connectivity.
Yeah, actually, it's a cruise ship now, so they have all those facilities.
Raju, a point note kiya jai. The first time I am doing a session for somebody in the wide open sea.
Yes, sir.
Very good. Thank you. Uh, in my excitement at seeing Abir, I changed the slide without realizing it, and I'm trying to go back one. Okay. So Abir, thank you very much. Paracetamol should have been given at least 6 hourly. Morphine 10 milligram 4 hourly may be okay, provided the patient understands what is 4 hourly. The patient should understand that patient should have one tablet when he or she wakes up, one at 10 a.m., one at 2 p.m., one at 6 p.m., and one at bedtime. No, two at bedtime. And they should know, every patient needs to be told, if you forget to take it at 10 p.m., 10 a.m., don't worry. Take it when you remember, but don't delay the next dose. Because they have taken this at only 11 a.m., don't try to make the next dose at 3 p.m. They will get confused then. Next dose take at the appropriate time. That's what you should be teaching them. Bisacodyl 10 milligram SOS. Comments, please.
It should be on a regular basis, every day.
If you are giving morphine regularly, bisacodyl has to be given regularly at bedtime every night. Not SOS, not acceptable. It would be a rare patient who will be okay with the SOS, but not acceptable. Gabapentin 200 milligram BD. Comments?
At least 8 hourly, sir.
No, not needed. But read this. Yeah, Abir, please read this out.
Yeah.
Louder.
Okay.
No, you're.
Yeah, Amitriptyline is the first-line treatment for neuropathic pain in cancer. While gabapentin has been widely prescribed in 2017, it was rejected for inclusion in the WHO model list of essential medicines on account of fraudulent evidence.
Gabapentin and pregabalin, that is gabapentinoid medicine, they are practically the same thing with a little twisting of molecules. They may be effective, but today, you know how expensive they are. You know how poor many of our patients are. But it is not only a matter of cost. And you have been recently hearing more and more about the gabapentin deaths in the USA. But leaving that alone, in this, I have given the link. If you look it up, they have given 5 references, proved beyond doubt that companies falsified evidence, promoted gabapentin and pregabalin aggressively, and much of our faith in the medicine depends on this fraudulent evidence. So learn how to use amitriptyline. Let us not abandon it because it is inexpensive. Because it is no medical representative will come and tell you about amitriptyline. They won't because it is too inexpensive. I'm not saying that gabapentin and pregabalin are useless, but I'm saying that today, based on available evidence, they cannot be first-line drugs. Okay, I'm not going into the details of this, but I'll go on now after our preparation has over about how we prepared reviewed, and now we are going to the 3 steps in difficult pain management. I don't know how many of you have experience with morphine in this group. Are there some people who have actually used morphine? So what Sunil and I find, and everybody will find, is that a proportion of your patients will have some relief with morphine. And at some point of time, you increase to from 5 to 10 to 15. Okay, the patient says some pain relief, but not enough. Pain comes back after 2.5 hours or 3 hours, and you increase it to 20. And next day, you get a frantic call from the patient's spouse saying the patient is behaving abnormally. There are jerky movements, it looks like fits, or she is talking rubbish, or she is too drowsy. These are symptoms of neurotoxicity with morphine. We have reason to suspect that much of neurotoxicity may be because of a genetic predisposition. I cannot really quote numbers, but maybe something like 20% of us would have a genetic predisposition which would predispose us to generate more of M3 glucuronide. This is the usual pathway when you give morphine. In the liver, morphine gets absorbed, goes to the liver, and liver converts it to all these metabolites. M3G seems to be responsible for neurotoxicity. And those people who create more M3G in their systems will have more chance of neurotoxicity. Whereas M6 glucuronide appears to be analgesic. If I take morphine, my pain relief will be more because of morphine and because of morphine molecules, but also because of M6G molecules. In fact, M6G appears to be longer acting even than morphine and more potent possibly. You're not sure. The others, if they have pharmacologically active, we don't know. Okay, you see the implication. So how is it important to us? All these are produced in the liver. So if we can avoid the liver, at least partially, this will be produced less. More of morphine molecules will be effective. How can we avoid the liver, at least partially? Think. How does it get to the liver? Raju, are there any answers in the chat?
Sir, sublingual parenteral route.
Very good. Who said that?
Parental route was said by Dr. Bismi and sublingual Dr. Starlin.
Dr. Starlin, Dr. Bismi, both of you are absolutely correct.
Dr. Avinash says
But
enterohepatic.
sorry?
So Dr. Avnish says it is enterohepatic circulation.
Yes. So, Starlin, yes and no to Starlin. Yes to the others. Hey, what's happening with me here? What are you seeing on my screen?
Sir, it's the metabolism, the metabolites of morphine.
I don't know how to handle this. Starlin's point is that if it is given sublingually, it would bypass the liver most often because it is entering directly into the bloodstream. But unfortunately, morphine is not well absorbed sublingually. Sublingual absorption is very poor for morphine, unlike buprenorphine, which is very lipid soluble. Poorly lipid soluble substances are not good for sublingual application. So, Starlin, sublingual may not work, but as Bismi said, the parenteral will work well because as who said enterohepatic?
Dr. Avanish, sir.
As Dr. Avanish correctly said, from the stomach, it enters the liver. And if you are putting directly into the IV line or a subcutaneous line, most of it will bypass the liver. Only a small amount will go to the liver. So remember, morphine is one medicine which can work much better parenterally than orally. That is true. Oral morphine is great, but there will be a minority of patients who in severe pain may need another approach. But apart from that, we'll come to that. One of the things that we can do when the former change happens, when we find this that there is neurotoxicity, one of the things that we can do is to switch from morphine to another opioid. In India, the only other opioids of step 3 that are available to us, because we don't have drugs like oxycodone, are methadone and fentanyl. Fentanyl is about 150 times more expensive per day for the patient. Remember that before you, in your eagerness, prescribe fentanyl. If fentanyl is used, it should be after stabilization with morphine and adjusting the dose. Methadone is inexpensive. Same, if you can get morphine, you can get methadone also. Placing an order. Sunil, are we doing in any session? Are you going to talk details about methadone at all? Is it part of our foundation course curriculum?
Yeah, basics, only basics.
So,
It was taken in opioids.
ladies and gentlemen, so you will have to use methadone. Be prepared. Methadone, when you have a patient who is not tolerating morphine, who has particularly with something like neuropathic pain, you use methadone, but ring up Sunil. Sunil has 20 times more experience with methadone than I. He is the expert. Ring him up or ring up Arjun, people like that. Get their guidance and use methadone with caution. It has a more narrow margin of safety than than morphine, which is why I am saying that it should be used with greater caution. Secondly, as Avanish said, and as Bismi said, bypass the liver. Give the morphine parenterally, provided you can admit the patients or monitor the patient at home. In Western countries, they routinely do it. Put up a syringe driver. Raju, Sunil, somebody, can you show what the syringe driver is?
Rajlakshmi?
So can you see it?
Closer to the
Yeah.
camera, please. Closer. No, not enough, Raju.
What am I supposed to-
That's a machine called a syringe driver. I wish a syringe was attached to it, where the forefinger is. Who is it? Vishnu's forefinger is. The syringe goes in, and the machine will keep pushing in the medicine at a speed that you have set. That doesn't matter. I mean, this is not the time to show it in detail. Maybe, I don't know whether during the session on nursing care, this can be demonstrated, Sunil. Thank you, Raju.
Okay, sir. Let me see.
I mean, just so that they are aware of this. This costs something like 40,000 rupees, the equipment, but it's reusable. The only recurring cost is a syringe and a scalpel inset or an extension tubing. That's all. So, the two things that in the revised regime I mentioned, opioid switching from non-opioid to methadone. Secondly, trying parenteral administration of morphine. And 3, treating central sensitization. In a early part of your course, when I talked about pathophysiology, I talked about several changes that can happen in the nervous system, including sensitization of the peripheral nerve ending and recruitment, the sensitization partially treated by NSAIDs. I also mentioned sensitization of the dorsal horn cell. The dorsal horn cell getting so sensitive. This is the peripheral nerve ending, okay? This is where the injury or the tumor is irritating. Electrical impulses are coming here. Once the dorsal horn is sensitized, for every impulse coming from here, numerous impulses will be going to the brain. It will multiply in geometric proportion so that at the end of a week or 2 weeks, the patient will have very severe pain because more and more impulses are going there. And we happen to know that the responsible neurotransmitter is N-methyl D-aspartate. N-methyl D-aspartate. Even if you forget the full form, it is not a crime. So we have to, in this situation, we may have to use a medicine that will reduce central sensitization by NMDA antagonism. Now, the anesthetist in this group will immediately name a medicine that causes NMDA antagonism.
Ketamine, sir.
Ketamine. Ketamine, which we use as a general anesthetic agent, in very small doses. Who said ketamine?
Dr. Bhagyalakshmi, sir.
Bhagya,
Yes, sir.
to induce an anesthesia, you will give at least 2 milligram per kg.
Yes, sir. 1 to 2 milligram per kg.
Reduce it by 10. Well, actually, Bhagyalakshmi, depending on how sedated the patient is not, you may have to go up to 5 milligrams per kg.
Yes, sir.
But here, you use 1/10, 0.2 milligram per kg orally. And I'll tell you more. So it is not an anesthetic dose. It's a sub-anesthetic dose, which is typically given. Typically can be with a syringe driver, but not necessarily as an infusion. You don't have a syringe driver, that's okay. Give it 6 hourly. The same dose you divide by 4 and give subcutaneously 6 hourly. The starting dose for a 50 kg person is this much, but remember this is over 24 hours, not at a time. Over 24 hours, they are getting only about 2 milligram per kg or less. If you are giving 4 times, only so much less. So a small dose of ketamine given as an infusion for 3 to 5 days. It can be with an infusion pump, it can be intermittent injections, can treat central sensitization. What it will do is to quieten, antagonize the NMDA, quieten the dorsal horn, make it normal, close to normal, and help in recovery and improving pain relief. Okay. But that means we'll have to admit the patient, right? For giving a 24 hours infusion or even 6 hourly injections, that's a difficulty. So oral ketamine can be given, particularly in the home setting in developing countries, it is more used. Now, earlier we mentioned the disadvantage of first pass metabolism. Now I am saying the reverse. Here, the hepatic metabolite is actually more useful. The hepatic metabolite called norketamine is believed to be pharmacologically active, and therefore the first pass metabolism may make the oral route even more efficient. It is bitter and can cause nausea. In the beginning, you may have to give an antiemetic acid using morphine, and you may have to mix it with a well-sweetened drink to avoid the bitterness. But the same preparation used for injection. Hey, everybody listen to this. Ketamine, oral ketamine is not available in India. As far as I know, I don't know if something became available recently. Somebody was telling me something like that, but I have not seen it. Injectable ketamine can be drawn from the vial and used orally. Mix it up with something sweet, like coffee or tea or a fruit juice. This is the dose. Start here. This doesn't mean that you should start at 0.5. Start at 0.2 and slowly build it up. If there are side effects, reduce it. Patient may feel lightheadedness, saying something wrong, I don't understand what it is. Stop it and restart at a lower dose. Which makes me wonder, Sunil, how Stanislaus is doing. Maybe later we'll find out about Stanislaus. I have given you the reference for this. It has a limited place for add-on therapy. In complex pain in pain patients, if other or therapeutic options have failed. But you should be conscious of two side effects of ketamine. One is hepatic injury. All that you need to do, what Sunil does is, before starting ketamine, he will draw a blood sample for SGPT. Check SGPT, keep checking it every 3 days. 3 days is not an absolute rule, it's not a WHO advice. We usually do it that way. If you find SGPT is rising significantly, you will have to stop the ketamine, unfortunately. Secondly, every day ask the patient for burning micturition. Patient may not complain of this. You culture the urine, patient complains of burning micturition, culture the urine, it may be sterile. But the same symptoms can cause long-standing, sometimes permanent burning micturition. So if there is vesicopathy, you should not continue ketamine. If the patient complains of burning micturition, withdraw it. Urine will be normal microscopy and normal culture, but it has to be withdrawn. Okay, so going back to this, in the based regime, first we talked about opioid switch. I recommended methadone, which is inexpensive. We said we can bypass the liver and try parenteral opioids if facilities are available. And thirdly, I mentioned ketamine. So those were the many steps that we mentioned. Remember, this is not complete. I've excluded some things which may not be safe, like intravenous lignocaine, I have not mentioned. We may include among the adjuvants in some selected cases. This is not exhaustive. But I told you about the 3 steps in preparation: believe the patient about the pain, correct the correctable, check adherence to treatment. In review, I mentioned check the emotional status. Think about intervention and non-pharmacological measures. And are we review our medication, review the nature of the pain and our regime. And then we go on to opioid switch. Several measures including local anesthetic. I'm sorry, Raju, you must remind me to change that slide. And ketamine, parenteral administration and ketamine. And ladies and gentlemen, I'll now go to step 10. You have done all this. Everything fails. Everything fails. Unfortunately, friends, we will come across this situation. We said that 3/4 of all pains will be okay with simple application of the ladder. For the other 25%, I said, do these. Even if you do all this, there will be that 5 to 10% of patients who will not get pain relief with whatever we do. What will you do? As I said in the beginning, do not blame yourself. If you blame yourself, you will start blaming the patient. You are not God Almighty. You are only a doctor. You are not an engineer like Raju. Engineers work with precision equipment. They know equipment inside out. They can be precise. Unfortunately, medicine. Hey, did you know that Raju is an engineer with a master's in engineering degree? Anyway, that is a diversion, by the way. But we, unlike superior creatures like this, are imprecise scientists. We deal with a machine that we don't understand fully. We give treatments which we do not understand fully. We have to have that humility to accept that we will fail. Repeatedly, I've had this experience of having to sit down with patients and tell them, I'm sorry that whatever I have done so far has not relieved your pain. And let me tell you, remember, one person that I'll never forget is Patu. Patu had a severe neck pain. We could not get her to have a surgery. That was too risky, and the surgeons did not want to operate. And I told Patu, sat down with her, Patu, though I have given you every medicine possible, I know that you have not had enough relief. Do you know what Patu did? Patu grabbed my hands, held it and said, please don't ask me not to come back here. Please don't ask me not to come back here. This is the only refuge for me. I want to keep coming and seeing you all. Patu's lesson is that we should not desert patients. Never desert the patient, never desert the patient, never desert the patient. They need us. If a patient is dying, we may use sedation, palliative sedation. At some point during the course, palliative sedation will be mentioned. It is not something that we do routinely, maybe 2 or 3 times a day. A patient close to death has intractable pain. You may sedate so deeply, not enough to cause death, but to make the patient sleep. But that is ethically possible only if terminal, but not for Patu, not for several patients that you will see. I tell patients, I'm sorry that everything that I have tried failed. There are some people who say that we should never that patient tell the patient I am sorry. I don't mind really. But I'll also immediately add, we will continue to be here for you for anything that you need help with, though our medications have not reduced your pain significantly. Because remember, no other doctor will want to see them. Everybody will reject them. They may still need us for psychosocial support. Remember, we are palliative care doctors. We are not needle happy anesthetists like what I was at one time, looking only at nerves and pain. We are palliative care doctors. We are not here to treat only physical pain. They need us. Promise that you will be here. For anything that we can help with, we will continue to work with you. That is the sensitivity that I am talking about. Convey it with sensitivity. Reassure of our continued support. And in between, the pain will worsen. That is natural. and then we may be able to do something about it. Ladies and gentlemen, with that, I'll stop this session. I'll stay with you for another 5 minutes to take questions. I'm sorry that I'll leave you to Sunil and Raju uh, because I have to join another meeting at that time. So, questions and comments.
You can ask questions or you can write it in the chat box.
So can I ask a question? So
Yes, please.
in our hospital, we had our patient. She had a terminal breast cancer. She went through a one session of chemo, but the cancer reoccur, and she came with us for a very bad fungating mass, and she was in so much of pain. So when she came, we started with morphine, very low dose, immediate release, 10 mg.
Okay.
Yeah, and then, but the pain was not relieved, and we were trying to review. And there was we also had our palliative consultant, and I'm working as a medical officer here, and we tried everything. I think we increased morphine dose up to 30. I think she was up to 60 milligram in 24-hour, but she had some side effects, like she was a bit drowsy. And but now you're saying that we should have, or we didn't go for any parenteral morphine. So I reckon it was, for us, we should have gone for a parental, isn't it, sir?
Doctor, how do you pronounce your name? Dam or Dum?
Dam Kumari, yes.
Kumari, where are you from?
I'm from Nepal, sir.
Dam, I'm glad you gave up to 60 milligrams. And then the patient was drowsy and you stopped. This is for everybody. There is
Yes,
no
sir.
upper limit to the dose of morphine. Actually, for a fast growing tumor in a 17-year-old girl, once I gave up to 200 milligrams hourly, and she was not drowsy. But in this case, she had side effects. Dam Kumari, understandably, did not increase it.
Yes,
Yes,
sir.
Dam. Yes, Dam.
Yes, yes, sir.
So what would I do, Dam? I'll go through my steps. I would believe her when she or he says that she is in pain.
Mm-hmm.
I would check whether she's actually taking the morphine in, or is it still under the pillow. I'll look for psychosocial issues. Remember, psychosocial issues.
Yes,
When
sir.
somebody,
We touch based on the psychosocial issue
very
as
good.
well.
Very
Yeah, the fact that there was no one to support her. Her husband was a drunkard, and then he was not supporting. She has a very, I think she has a 10 years old kid at home, which was very remote. So we did touch base on that issue as well. Yes, sir. But we were not able to, I don't know, manage, or she had that side effects. We were so much in dilemma, how to, relieve the pain, and with those side effects coming in. Um,
Dam Kumari,
yes,
you have
sir.
my respect. You have my respect because you know the patient so well. You knew the family. You knew about the family psychosocial factors.
Yes,
Very good.
sir.
Very good. Uh,
Thank you.
I hope when my time comes, someone like you treats me. Yes, in short answer, there are many things that we could have tried, but one of them, certainly first line, is stop the oral morphine.
Mhm.
Give her small aliquots of parenteral morphine. Try her on parenteral morphine. This is not pure theory. In a proportion of patients that actually works, they become fairly comfortable on injectable morphine. But do you also have access to injection fentanyl?
In Nepal, no, sir.
Okay.
We don't. Yeah.
So you could have tried, future. Um, if you have another patient like this, I
Yes,
think
sir.
you should try injectable morphine. And are you in Kathmandu?
In Pokhara, sir.
Okay. So, there are a couple of things that I can think about them.
Yes.
One is that an earlier step that I mentioned, it is in the chest pain, right? Pain is in the chest.
Yes, sir.
Convey.
On the right,
So
right chest region. Yep.
maybe your anesthetist could have put in an epidural catheter into the thoracic spine and a small infusion of or intermittent doses of uh, local anesthetics plus tiny dose of opioids could have been given into the thoracic space if you have the facility and if your anesthetist has the expertise. And finally, certainly this if your parenteral did not work, this is a patient who could have improved with methadone if it were available. It may not be, or with ketamine. So,
Yes, sir.
in future when you have problems like this, I
Yes,
hope
sir.
you and we can work together to relieve the suffering of those patients.
Definitely, sir. Sure, sir. Thank you. Thank you for your response.
Do you know Dr. Bishnu Datta Padal in Kathmandu?
Uh, yes, sir. I think he's the head of our who's looking after palliative care in
Yes,
Nepal.
yes.
Yep.
He's
Yes, sir.
with the government.
Yeah.
And he is somebody who can make anything available. I have not
Sir.
seen very few people who have as much a push as he has. So getting methadone, etc., will not be very difficult for him if he wants to.
Sure, sir. Thank you for your consideration.
Okay. Thank you, them.
There are two questions in the chat box, but
So, sorry, Sunil, I am leaving. I leave the questions with you.
okay.
Sorry. See you later, everybody.
So one question was regarding the gabapentin in non-cancer pain. So WHO talks about the use of gabapentin in cancer pain management, and they say it is the created evidence. So uh, that will be applicable to I think for non-cancer pain also. So what essentially it means is there is a tendency to write or prescribe gabapentin or pregabalin for all the patients. Okay, and that we have to reconsider whether we need to really prescribe gabapentin for all the patients. So we usually use sodium valproate here. And another question was usage of gabapentin in pediatric population. Dr. Lada, are you there?
Yes, sir, I'm there.
Yeah, so I think you can answer this question. Do you use gabapentin in pediatric patients?
Not, sir, not regularly.
Okay, but it can be used, isn't it?
Yes, sir. Yes, sir.
Yeah, yeah. And what is the dosage, if you remember?
Sir, I mean, the thing is, it is referred to neurologist and they come and go to the neurologist on OP basis and get the doses corrected up. So we are not so confident in procuring or in giving the doses. So we generally refer to neurologists. They will prescribe and they'll come back to us saying that they have got the medicines. So I have not actually titrated or started the dose by myself to be confident enough, sir.
Okay. So I have seen my colleagues using gabapentin in pediatric patients, but I'm not sure about the milligram per kilogram dose. And there is another question regarding palliative sedation. Yeah. Anybody knows about palliative sedation? Okay. So palliative sedation is the sedation of the patient when the patient has intractable and refractory symptom. So what is refractory symptom? A symptom that is not responding to the conventional treatment. So you have done all the possible measures to relieve. For example, suppose we take pain. So you have given all the possible treatment like all WHO analgesic data has been titrated. Then you have tried interventional pain management, maybe like epidural or something. But even then, the patient doesn't have proper pain relief. So that is called as refractory pain. And patient says it is intolerable for me. So in such situation, intolerable and refractory symptom, you can reduce the conscious level of the patient to reduce the suffering. So it is by reducing the conscious level of the patient by giving sedative agents. So that's what palliative sedation is. Dr. Avanish, is it clear? Okay, how is it done exactly? Yeah. So you have to sedate the patient with benzodiazepines. Uh, you can use lorazepam or midazolam. We usually give midazolam, maybe to start with 1 milligram midazolam intravenously or subcutaneously, and wait for 5 to 10 minutes, and then administer again 1 milligram. So this will make the patient drowsy after some time. You have to continue to give it maybe after 5 to 10 minutes. And once the patient is drowsy or sleeping, then you will follow up with a continuous infusion of midazolam, usually midazolam. And if you give midazolam only, benzodiazepine only, then there is a chance of more excitement. A patient may have delirium also. So in order to reduce that, you can also add small dose of antipsychotics like haloperidol. So this is what commonly done. But if you look at the literature, various agents are used for sedating, for palliative sedation. So it varies from benzodiazepines, diazepam, midazolam, lorazepam, phenobarbital, haloperidol, propofol, uh, even thiopentone. So yeah, you have to actually, if the patient has the mental capacity, that means patient has all the information with the patient. We have to first discuss with the patient uh, regarding palliative sedation and what are you expecting and how are you going to titrate, etc., etc. So if the patient says, okay, I understand fully, then we can go forward, but also take the take the consent from the family, because in our culture we have to also discuss with the family. So if both agrees, go forward, and actually we write it in the case sheet. There is no such separate form which we use, but we will discuss, we will write it in the case sheet, what all have been discussed, who all were present, etc. And that will serve as the medical legal document. Okay, so medical legal aspect. If you look at palliative sedation, actually, you cannot see anything which or any law endorsing palliative sedation as such. But if you look at outside in the Western countries, they have legalized palliative sedation. So, and one thing is that our constitution says the patient or all of us has the right to live with the dignity till death or even during the dying process. So there are many clauses like that in our constitution which will provide us the safety. And if we don't have any medical legal document on this, then the courts look for other documents in the other countries. And there are many countries which practices palliative sedation. So it should be okay for us also. So, okay, regarding palliative sedation, is it like using dissociative anesthesia or just like using proper dose of opioid? No. As I told you earlier, palliative sedation means reducing the conscious level of patient by using sedative agents. So you have to actually sedate the patient to reduce the suffering. So you will sedate the patient up to the level that patient will not experience the suffering. That's what happens. I think we will send you some articles on palliative sedation. So I think we have to move on to patient story. So what we have discussed is difficult pain. What are the steps involved when a patient without proper pain relief comes to you? So it is very important for us to remember that uh, many even as are told, we are not compliant with medication. So that is one of the most common reasons for improper symptom control. So whenever a patient comes with uncontrollable symptom, you should ask, actually you should take the tablet and ask the patient, when are you taking this? Tell me, do you know what is it for, and what are the timings are you going to take it? So that information we should get. Otherwise we will ask, are you taking medicine properly? They will say yes. So there is, then we will increase the medication actually, but that should not happen. We have to actually take the medication and show it to them, ask them, when are you taking it? So this is very important because I have seen many patients are not compliant. Even many of us are not compliant with medication. So we should know that. And another important thing is changing the route of medications that you are giving. So changing oral morphine to parenteral morphine, or switching to another opioid like fentanyl or methadone. Uh, and sometimes NMDA antagonists like ketamine would help. Uh, so methadone is another medication which also has NMDA property. Okay, so these are some important points that we have discussed, and we have to also understand that we are not the God. So sometimes we have to accept that patient doesn't have symptom control, but we will discuss it with the patient. And uh, as are told, don't desert the patient. So thank you. I think we will move on to patient story. Sarayalakshmi,
Dr.
can you
Madhu.
share the patient?
Yes, sir. Dr. Madhu, can I share the presentation?
No, I would like to share the presentation. So, good evening, everyone. Am I audible?
Yes, doctor,
Yes,
you are.
yeah.
Okay. So, I'm Dr. Madhu. I'm a junior resident in the Department of Medical Oncology in Father Mullers, Mangalore, Karnataka. So, today we'll be talking about a 65-year-old male who is a known case of CA bladder, stage 3B. He also had coexistent acute kidney injury and recurrent complicated UTI. So coming to his presenting complaints, so I've classified his complaints based on severity. So his most severe complaints were severe abdominal pain, lower abdominal pain, and hematuria with lower urinary symptoms like increased frequency of micturition, burning, hesitancy, all the that group. And then he also had the next set of complaints were constipation with painful defecation, insomnia, auditory hallucinations secondary to insomnia-induced psychosis. And the next set of complaints were low backache, heartburn, indigestion, loss of weight, loss of appetite. So history of illness. So the patient was initially seen in the urology department in February 2019 with comorbidity. He has comorbidities of hypertension and type 2 diabetes. He was evaluated for hematuria, dysuria, intermittency, poor flow, and hesitancy. And at that point of time, the USG showed increased post-voidal residual urine, and he was just treated symptomatically for benign prostatic hyperplasia. On further evaluation at an outside hospital, which was, I believe, sometime later, since the complaints were persistent, and he went to a hospital close by to his place, and he was diagnosed. That time on evaluation, he was found to have carcinoma of the bladder wall. There, he underwent transurethral resection of bladder tumor in February 2020. The pathological grading was T4A N2M0, which corresponds to stage 3B. And the histopathology was high-grade urothelial carcinoma. Following that, that was February, March, that time. He was supposed to follow up after a month for following chemotherapy or all those sessions. But then COVID showed up and he was lost to follow up. 7 months later, in September 2020, the patient presented back to our hospital casualty with severe hematuria and severe lower abdominal pain. So here's what we did after he came here. So on examination, the patient was conscious, oriented. There was no pallor icterus cyanosis. Vitals were okay, stable. Per abdomen examination, he had suprapubic tenderness, and all of the systemic examination were within normal limits. So this is about his pain mainly. So his pain, so if you notice here, I've marked here, this is the worst possible pain he mentioned. So the clots in the bladder were blocking the urethral opening, causing severe pain at the root of the penis. And also there was burning sensation through the shaft of the penis. Both these were associated with an intense desire to void every 10 minutes, and the pain reduced in intensity after voiding but did not completely disappear. When asked to grade this, he gave a number 9. And then we have the perianal pain and the rectal burning, along with tenesmus. So this was found secondary to prostatitis. So the tumor was infiltrating his prostate. This predisposed him to develop prostatitis that got inflamed, and it was adherent to the rectum. So every time he passed stools, he has severe pain and burning in that area. So when asked to grade this, he gave a number of 8. Following that, the next site of pain was lower abdomen, more like radiation from the pubic region, and also sometimes he had independent lower abdomen pain that was due to recurrent UTI. And low back ache. So whenever all these other sites of pain was severe, he experienced pain, even at like a mild ache at the lower back that was of a low grade 3. So this is about his pain. So the significant investigations were CBC was normal, blood counts, renal function, creat was on the higher side, 1.49. Urine analysis was turbid, proteins present in urine, blood also present, numerous RBCs, WBCs. So USG was showing a huge lesion, a 7 into 3 into 7 centimeter lesion with internal vascularity, which is consistent with neoplasm. And also there were multiple heterogeneous mobile lesions consistent with the blood clots. and there was bilateral HUN despite having a DGS stent in situ. So we went ahead and did the plain CT, which was showing muscle plane involvement with perivesical fat stranding. And also there were multiple lymph nodes and HUN as mentioned. Urine culture group E. coli, which was heavy growth, more than 1 lakh colony forming units per ml of urine. So treatment, we immediately started him off with a 3-way bladder irrigation to remove the clots and to reduce the irritation. We gave him adequate hydration to improve AKI. Antibiotics were started based on the culture and sensitivity. Initially, broad spectrum was started, and then based on culture and sensitivity, it was switched over. The pain management was managed with analgesic titration. So as definitive management, he received palliative radiation, 30 gray in 10 fractions, and currently he is undergoing palliative chemotherapy with gemitrit and carboplatin. He finished only 1 cycle of it. Last on 12/11. That is to be noted because he's very irregular in follow-up, and the last we saw him was 9th of December, and that time he came with an active UTI, so we couldn't proceed with our chemotherapy. So psychosocial aspects. So his family, they are very pious Muslims. They are from an upper middle class family. He's married. He has 4 daughters and 2 sons. 2 daughters are married. He was working abroad, returned quite a while ago, and settled here with the family. So about his children, one point to be noted is his elder son was a known case of acute lymphoblastic leukemia who relapsed, status post bone marrow transplant. He recently deteriorated and he passed away almost, I think, 1.5 months back. And his elder 2 daughters had very small children, so they couldn't stay with the patient in the hospital. And the younger daughters were too small. The younger son, he is now the sole breadwinner of the family and is paranoid about getting malignancy himself. Because already he's lost a brother to malignancy and he's seeing a father who is also having a malignancy. So he's very paranoid about having a malignancy. And one more main factor here is that we noticed when the patient was in the hospital is that in the Muslim community, I believe urine is considered unclean and their prayers won't be accepted or something of that sort, which I'm not sure about. So this patient's main complaints, if you notice, was frequent voiding and leakage of urine. So every time that had to be cleaned, and that caused a huge amount of frustration. And the daughter who used to stay with the patient, each time the patient voided or there was a leak or they had to clean, and that was very frustrating for the daughter, the patient also, and that was reflected onto the staff in the hospital. So that was one thing. So coming to his medication, for pain relief, he was started off with the injection PCT. Ice pack was given for local application. He had willow patch, which is buprenorphine, 10 mcg changed every week. Then he was also given pregabalin NT, which is pregabalin and nortriptyline, BD, and enzofit was given to reduce the inflammation. And when he was discharged, it was converted to Dolo 650 TID, which I believe is a mistake. And we should have sent him in every 6th hourly Dolo. So coming to his other GI symptoms, he was given PAN, nodosis, which is soda bicarb. Endase was given, which is progestin, supradine forte multivitamin, aristozyme diastase enzyme to improve appetite, and protein powder. For the lower urinary tract symptoms, he was given Veltam. And patient had insomnia, significant insomnia. So during hospital stay, he didn't sleep for 3 to 4 days straight. And he started hearing voices, and that became very troublesome for him and the family as well. So he had to be started on an atypical antipsychotic, which is quetiapine. And for insomnia, he was given lorazepam 2 mg, which he still continues. For constipation and the painful defecation part, he was given Crema gel for local application and zircremafin. Complicated UTI part, based on culture and sensitivity, we started. He was given Eminem and tabceptran. So the main concern here is family support. So this patient, one thing I'm not sure of is if his wife, I've never seen his wife, And the younger son, as I mentioned, is paranoid, and the elder daughters could not stay in the hospital because they had younger children, very young children, and also because of that whole the urine thing. So that was also a very, so because of that, the whole family who felt it something disgusting, disrespectful to the religion. So they were not really supporting him and his disease. They were not ready to accept that part. And previously, this man was a very active man, but now he's not even able to do namaz. So that was also one more thing that the patient was little upset about. And they stayed 3 hours away from the city. So it was very difficult to bring him up for follow-up visits. Analgesic compliance was very poor. So every time he got admitted, we titrated the analgesics and put him in a certain thing, and we send him home. But by the time he comes next, he comes in severe pain to the casualty again, saying he's in severe pain. Then when we ask him what he's taken, on detailed questioning, we find out that he's not taken a lot of analgesics that he was on. He's not changed the buprenorphine patch that was given. So polypharmacy was also there. So as you see, I've put on a lot of medications that he was on. So it was very difficult for his compliance as well. So, and once this pain sets in, it was very difficult to get it back to control. Follow-up was very irregular. Like as I mentioned earlier, he was supposed to come for chemotherapy regularly once in 3 weeks, but he didn't show up. And when he comes with some complaint or the other. So we won't be able to proceed with the proper regime that we had planned for him. So hematuria, the clots, the complicated UTI, they tend to be very recurrent. And insomnia due to the severe pain, and it was also associated with hallucination. And yeah, this point, I would like to highlight this point. The muscle invasive disease, it was infiltrating prostate, but there were no distant metastasis. It was only loco-regional recurrence. So this doesn't affect his lifespan per se, but it severely affects his quality of life, which means he's going to be staying for a long, long time with the same amount of pain. So there was something we have to definitely do about this. We were a team of doctors in our hospital who were taking care of him, medical oncologists. I'm a junior doctor in the same department, a urologist, pain physicians, gastrosurgeon, nephrologist. For each complaint, we had like one department CA. So the problem with having so many specialties involved is that the patient is followed up, the patient came for follow-up with only 1 or 2 doctors during the hospital visit. So the other complaints were like neglected by the patient, or he didn't go to the doctor in concern. So it's like, because he didn't go there, that part was neglected. So that had to be somehow, that's a concern, I feel. So in summary, we had a 65-year-old Muslim male, head of an upper middle class family, supported by a wife and 6 children with comorbidities of diabetes and hypertension, diagnosed with carcinoma bladder stage 3B, presented with main complaints of pain, hematuria, GI complaints, and insomnia. He was temporarily managed symptomatically, but long-term management is difficult due to a lot of factors, as I've discussed already. So the points that I would like to discuss here are how to improve family support, tips for counseling this particular family, and how to avoid polypharmacy and improve patient compliance. How to manage difficult pain in this particular patient, because even though we, achieved proper analgesic titration, compliance was poor. And then once the pain sets in, it's very difficult. So each time he comes back, we're scared if we won't be able to manage him of his symptoms well. And how to avoid hematuria and passage of clots, which of late has become a very often is presenting complaint to casualty. So that somehow I wanted to know if there's any way that we can keep that under control, because then further hematuria might cause his HB drop and things like that. And he's highly prone to complicated UTI. So how can that be prevented? Should he be on prophylactic antibiotics? I'm not sure. So I wanted to know that. And how to achieve loco-regional symptomatic response. So he's received radiation that might have shrunk the tumor a little bit, but he's not regular with chemotherapy. And yeah, loco-regional symptomatic response, how can I really achieve in this patient? And how to improve his quality of life? That is my most important question. How do I improve his quality of life?
Thank you, Dr. Madhu. So we have, of course, very challenging patient story here. So we will ask the group what shall we do in what can be done in this patient.
Yes, sir.
Yeah. Any of you can come. Any question? Anybody? You can comment on any question. We have to help Dr. Madhu. Palliative care is not only for the patient but also for the professionals, because we are also stressed.
So regarding this family support, Dr. Madhu was talking that there was nobody to take care of him. Actually, she have not seen the wife, and the kids were too small, and the other boy, the male, actually he was a little worried also. So the first thing is now, like, we'll have to go into what happened and why there is. We'll have to inquire like what happened to the wife, why she's not able to take care of him. Usually, most of the time, usually what happens is most of the time it will be the wife who will be with their husband, and they'll be the one who is building up, because almost they, like as she told, the male, they'll be the breadwinner, so they'll have to go for work and all those things. So mostly it will be the wife, and if not that, like if there is anything else, maybe maybe divorce, separated, whatever. That is one thing. And as Dr. Madhu was telling, he was very much concerned about this, his prayers. And it's a common thing which we all, every time we come across when with Muslim patients, even myself as a Muslim, so I know, because every time we ask them for something, they'll ask us like, how long is this procedure going to take? If you put me an IV cannula, will I be able to take, will I be able to pray? So in this scenario, and as she told, like, the urine, actually it is considered as unclean as per the Muslims, and we need to clean it before the prayer. So I think he since he was on a catheter, that actually would not be having an issue. He can do that if he's on a catheter, unless it just the urine, if his dress is clean. So to encouraging him to do that, it is okay to do the prayer with a catheter is one thing. Most of them doesn't know that if they think that if they have a catheter on, they cannot pray. So that is one thing which would have been helped. Another is his pain control. That is going to be a little difficult in this case, because it's the bladder thing. It's very difficult to control the symptoms coming from the bladder. I don't know, maybe something to relax the prostate muscles, the detrusor muscles, bladder muscles. I don't know what we can do in that case. Maybe opioids. I don't know. I don't know whether that is going to help or not. And this patient is actually poorly compliant from the beginning itself. That is another thing. Somebody have to counsel him regarding this importance of being compliant, and the quality of life which he may be able to maintain if he be compliant, including this maintaining these prayers and those things, which they find it as an important thing in their life. Or maybe that is the only thing what they wanted. They just want to pray properly before they die. So maybe convincing in such a way may be helpful. That's all from my side.
So I see some chat comments also. We should try to organize that maybe from another religion or community. Talking about social support. And if you can't clean yourself due to illness, then you may still pray. That's my understanding. And that's by Dr. Disney. And this patient needs to be followed up from hospital side instead of waiting for it to comply and turn up. Okay. Needs proactive strategy. Yeah. Thank you, Dr. Avinish and Dr. Abir. So, what you have told is very important. We have to understand the family dynamic. As Dr. Abir told, uh, we have to actually talk to the patient and ask about the wife and then only we can understand more about the family dynamics. And if possible, if there are no problems, then we can call her. Maybe one of the social worker in your team can call the patient's wife and ask her to come and have a discussion with patient, with wife. And you are also told that there are two daughters who has who usually do not come to hospital because of young children, but we can also talk to them over the phone and also take their help. uh, mm, I think just want to ask Dr. Madhu whether the patient knows about the disease.
Yes, sir. Patient knows. Patient is well aware about the disease.
Okay. So that's what one thing which we have to understand, because if the patient doesn't know anything about the disease, then usually the compliance with the treatment will be less. And we should also try to engage the patient with talking conversation regarding the importance of treatment. I'm sure you might have done that, but it would be nice if he can, if there is somebody who can talk to him regularly. Uh, uh, Polypharmacy, regarding polypharmacy. So, whether we have to actually review the medications, whether all those that we have written is actually necessary, and we can reduce some of it. So this may also need help from the colleagues from other departments, because they might have written many other medications. So I think as a palliative care physician, it's our duty to coordinate the care of this patient, so that sometimes we may be able to reduce some of this. And for auditory hallucination and insomnia, I can see that there is quetiapine as well as lorazepam, which might need, which may be necessary, but we have to also understand that the quetiapine in lesser doses have also sedative property. So maybe we can try to reduce the dose of Ativan and gradually taper it and stop, and see whether only quetiapine will help the patient. And regarding bipolar patch, that is buprenorphine patch, we will not be able to titrate the dose according to pain with any patch. So if this patient has recurrent exacerbation of pain, then if morphine is available, I think it will be better. Another thing would be this patient has recurrent suprapubic pain along with burning pain inside the shaft of the penis. So the clot may be one reason for burning reason inside the shaft of the penis, but I have seen a few patients who typically complains of pain on the penis as well as suprapubic pain. So this usually occurs because of the contraction of the detrusor. So this will be severe pain, and it will come recurrently. So what you can do is you have to give some medications which relaxes the detrusor muscle. So there are many, but uh, oxybutynin, which is an anticholinergic, which specifically acts on bladder muscle, would be helpful, I think. So oxybutynin, maybe you can start with 5 milligram BD, and usually maximum dose is 30 milligram per day. If this patient has recurrent clot problem, that is, he is continuously bleeding, then I don't know whether any hemostatic radiation will be helpful at this stage, that you have to discuss with your radiation oncologist, because many of the patients will get relief for bleeding with hemostatic radiation.
Yes, sir, but he's already received radiation to that area, so I believe it can't be repeated now.
Okay. So then we have to give some systemic uh, uh, medications like ethamslate or tranexamic acid. But the problem with the tranexamic acid is that it can again produce clot. So that's a problem with the tranexamic acid, which will not occur with ethamsulate. But I think this patient, if continues to bleed, might require the three-way catheter. So that you have to teach the family how to irrigate the bladder with normal saline, which we usually do to our patients. So that whenever they can irrigate, that's one option. And it is well and good if the bleeding stops with the ethamslate or tranexamic acid. Okay, then the patient is getting NDAs, that is NDAs is megestrol acetate, supradine, aristocyan. So if you look at from the evidence regarding the appetite stimulant, only megestrol acetate has proven efficacy in improving the appetite. Aristocyan doesn't have that much evidence. So maybe I think if it is possible for you to cut aristocyan and supradine forte, that will be good. And megestrol acetate can be given for loss of appetite. Okay. So the difficult pain, which we have already discussed, one problem in this patient is compliance with the medication, and maybe change Bovalar patch to more or the opioid which we can titrate, like tablet morphine.
Yes, sir, but morphine, since he had renal functions were deranged, I think that was the reason morphine was not tried on him.
But it is 1.4. That should be okay.
It was fluctuating, sir. This
Okay.
was on admission.
Okay. So yeah, if methadone is available, that would be good.
Okay, sir.
Methadone is another renally safe opioid. Then we talked about hematuria and how can, if you teach the family, that will be good. They can manage at home itself. And regarding the prophylactic antibiotics, anybody has any opinion regarding prophylactic antibiotics in this patient?
Those who are having a recurrent complicated UTI, I think a prophylactic antibiotic is recommended. Probably that would have been started by the urologist. Usually they start it for every complicated UTI, or at least for 6 months or something. Somebody has commented nitrofurantoin is the one usually they starts in the
nitrofurantoin. Okay, so I have seen many patients receiving prophylactic antibiotics, but when you look at the evidence, they say there is no role for prophylactic antibiotics. So if you look at the CDC, Center for Disease Control USA, they say there is no role for prophylactic antibiotics. So that is something which we have to discuss with the urologist and then take a decision. But you have to also keep in mind the evidence which is present now. How to achieve locoregional symptomatic response. So Dr. Madhu, I didn't get that question. Is it from the oncological point of view?
Not exactly, sir. So, yeah, all these complaints that he has is because of loco-regional recurrence. And since he's not regular on follow-up with the chemotherapy, I don't find a way from the oncology point of view to control his disease. So only a symptomatic response, if we can achieve, it will be very helpful for the patient.
Yeah, yeah. That's that's a problem because the patient is not compliant and not turning up for regular follow-up. So maybe I think if you can go more deep into the family dynamic, then that will help to achieve something. That's what I believe. Because patient may not have support from the family, which can also make the follow-ups very difficult. So maybe our first strategy would be to discuss with the patient regarding the family dynamics and then involve other family members in his care.
Yes, sir.
And how to improve his quality of life? That's a big question because quality of life is something which is decided by the patient, not by ourselves, not by the treating doctor. So we have to ask the patient, what is it going to help you? How can we help so that we can improve your quality of life? Sometimes the pain may not be his primary concern. His primary concern might be the relationship with his wife or some other thing. So we have to actually ask the patient and then decide what can we do for those problems that the patient comes out. Um, so definitely we have to give pain control. Uh, yeah, I see some other. Yeah, can superior hypogastric plexus block help? Um, I'm not sure, but maybe you have to discuss with the pain physician. And even if, yeah, maybe you can try. Give him his panda like girl in Dr. Rajagopal story on day one. Okay. Yeah, there is one comment on clean intermittent self-catheterization. Yeah, that's a good thing, but the problem is that this patient is getting recurrent catheter block or a recurrent pain every 10 minutes because of the clot. So it will be difficult for clean intermittent catheterization every 10 minutes. So I think it would be better if you go for in situ Foley's catheterization with the three-way. So these are some comments. And anybody else want to comment on anything else?
Hi, this is Dr. Ashish. I just wanted to confirm this patient had recurrent blocks, right? So, considering that I have seen a lot of cases with CA bladder as well as prostatic cancer patients, where these recurrent blocks are due to the cell chunks which you actually clog the catheter. So, using 100 ml Toby syringe when I was working in clinicals, so that was something that we used to do routinely, and that used to relieve the pain that patient used to get because of because of the blocks. The distended urinary bladder may provoke a lot of pain, so that also used to help with it. And along with you can see that a lot of debris you can take out with 100 ml syringe. So that is something we used to follow back in ESI when I was working.
Yeah. Okay. Thank you, Dr. Ashish.
Yeah.
So, Dr. Madhu,
Yes, sir.
anything else you want more clarification?
The patient is currently not catheterized throughout.
Mm-hmm.
So I want to know if catheterization, like complete Foley's in situ, will improve his symptoms.
I think that need to be tried because, as you said, if it is a problem with clots, then the three-way catheter and irrigation continuously for a few days, followed by as and when needed by the family. If you can teach the family, would be good, I think.
Okay, sir.
Dr. Madhu, was he registered with any palliative care services? Like you told, he's like 3 hours from your hospital area. So in his town, was he registered with any palliative care services?
No, I don't believe so.
So maybe that is something which maybe you could help. So that when you put a three-way catheter, there are people who can go there and in the initial first few days who can help him to do this bladder wash regularly, and then once later on, this family can take up.
Yes, I'll find out about a setup in his place about that. Yeah, that will be really helpful.
I think he's from Kerala, right? From what you told, I think it's.
No, he's from a place called Bhatkal.
Okay, that is right. Okay, Bhatkal means it's very far, right, from Mangalore.
Bhatkal or Bantwal? I'm not really sure of the place. Something, one of those two. Bhatkal or Bantwal.
Yeah. I think Bhatkal is almost 4 hours of journey from Mangalore.
Yeah. Must be Bhatkal. Yeah.
Thank you, Dr. Abhyash. Thank you, Dr. Madhu, and I think we have to wind up the session now. So we'll see you on next Wednesday.